Welcome to Talk Dizzy to Me, the show that brings you a comprehensive look into the complex field of dizziness. Now here are your hosts, vestibular physical therapist Dr. Abby Ross and Dr. Danielle Tolman.
Welcome back, everyone, to Talk Dizzy to Me. I am flying solo today. My name is Dr. Abby Ross. I'm a vestibular physical therapist, and today we have two physical therapists, two neuro nerds, two vestibuloholics, all of the above, who've both been on this show before. We're joined by Dr. Carly Lacala from our clinic, Balancing Act Rehab, and Dr. Sara McDowell from Dizzy Diagnostics. They're here today to help us brush up our knowledge and clinical skills around facial paralysis, which is a topic that's even affected Justin Bieber. I don't know if any of you saw his Grammy performance, but yeah. Carly, Sara, welcome to the show. Thank you so much both for being here.
Thank you. Yeah, thanks for having us. Really excited to talk about this. And George Clooney too, not just Justin Bieber and potentially Lil Nas X, like lots of celebrities and lots of other people too.
Yeah. Yes, you're right. I forgot about those two. Mm-hmm. So first, maybe just give us a little bit of a background in your experience with this topic. And why don't we start with you, Sara?
Yeah, so I work down here in Baton Rouge, Louisiana, and I'm in an interdisciplinary neurotology practice. And so facial nerve rehab kind of found me. I was doing vestibular rehab, but we work in a practice that is also an acoustic neuroma center of excellence. So we see a very high volume of acoustic neuroma patients. And when there is a tumor present, as we might talk about, it can affect both the vestibular nerve, but also the facial nerve. And so what we found was that patients were presenting with vestibular dysfunction, but also with facial paralysis. And there was nobody in our region who was trained to treat it. So about 12 years ago, I went up to Madison with Jackie Deals, who's very renowned in the facial therapy field, and was lucky to be trained by her. And then since then, we founded our own interdisciplinary facial nerve clinic. So I work with our facial plastic surgeon very closely and have been able to just kind of dive into this field as well. So my practice is actually about 50-50. I do about 50% vestibular work and about 50% facial nerve work.
Amazing. What about you, Carly?
Yeah, it also sort of found me. So I was working in outpatient hospital setting, and there was one therapist who saw pretty much all of the facial nerve conditions, whether it was like trigeminal neuralgia or something related to facial nerve, but all sort of cranial nerve involvement and headaches. And so that was her wheelhouse, and she needed help. And so as the neuro PT who loves exploring new things, I'm like, I'll do it. So I got trained on treating specifically facial nerve conditions. And then we started a facial nerve center at OHSU as well. And so we had started an interdisciplinary clinic, and it was so great starting to build that and figure out how do we work together and what do we need to do to put together something that's really comprehensive. And I've been able to do some trainings kind of on my own and through mentorship and with Jackie Deals and Susan Rankin and some of the other important names in facial rehab. And it has been really, really helpful and helping to, bring just more education to more people as much as possible.
I love it. Well, I'm excited because I don't often see this in my practice. So I know I have some sprucing up to do. Before we talk about facial paralysis and specifically cranial nerve 7, the facial nerve, I want to first give an overview of all the cranial nerves. And there are some mnemonics that some people say. I think one might be a little inappropriate for this podcast, but there are some PG-13 or PG, I guess, mnemonics as well. Who wants to share or take us through the cranial nerves and maybe what role each one of them plays for us?
I would love to do that as the resident neuro nerd and neuroscience educator that I am. So you have 12 cranial nerves, and I even brought my brain model along here. So for those of you watching, you can see my little brain model. But you have 12 cranial nerves, and they all kind of come from this region here, from part of your brain called the cerebrum, and also the brain stem, which is like right in here. And they have a surprisingly large range of things they do for us. So the first cranial nerve, that's your olfactory nerve. That's responsible for your sense of smell. So that's the first one. The second is your optic nerve. And this is the one that is in, maybe you're a little more familiar. This is when you have your eye exam at the eye doctor. This is what the eye doctor is looking at when they look really closely at your eyes. They're looking to see the integrity of your optic nerve, and that's for sight. Then we have cranial nerve number 3. That's your oculomotor nerve, and it has to do with some eye motions and also the muscle that opens your eye, your levator palpebrae. I love that name. And then you have actually 3 different nerves that help with eye motion, but we'll talk about all of those in a minute. Number 4, the cranial nerve 4 is your trochlear nerve. That's helping you with your eye movement, being able to look around. And then we have cranial nerve 5, which is kind of in the middle there. It's a large nerve, and it's responsible for a lot of things. Your sensation of your face. So anytime you're being touched on your face, that's your trigeminal nerve providing that information. But it is also in charge of providing innervation for your muscles for chewing. We call them your muscles of mastication. So anytime you're eating, you can thank your trigeminal nerve for that. So sensation of the face and muscles for chewing. Then cranial nerve 6, that's your abducens nerve. And this is for eye movement. If you're trying to give someone the side eye, the eye that's moving out to the side, that's going to be your abducens nerve helping you with that.
I never do that, by the way.
Well, now you know, the people that are giving side eye, you're like, abducens nerve. This is how my brain works. So then you get to cranial nerve 7, the facial nerve, which we'll be spending a lot of time talking about its functions in a minute. Cranial nerve 8, if you've listened to this podcast, you definitely know this one. That's your vestibulocochlear nerve for hearing and balance. And we'll talk about, today, the relationship between cranial nerve 7 and 8 and why, dizziness and some of the dizziness and balance conditions that we see sometimes present with facial nerve involvement. So we'll get there later. Cranial nerve 9 is your glossopharyngeal nerve, and this helps you swallow. Your vagus nerve, cranial nerve 10, a lot of people probably have heard of this. It's become more popular as of late, I think, in social media and in other arenas, thinking about how to regulate and tame your vagus nerve. But its job is to help kind of activate the parasympathetic nervous system. And it has a lot of connections all over the body to allow it to do those things. Cranial nerve 11 is your accessory nerve, and it provides innervation to some muscles in your neck and shoulders. So this muscle here, your sternocleidomastoid and your traps. And then we have, last but not least, cranial nerve 12, which is your hypoglossal nerve, and that helps with tongue motion. So when if you've ever had an exam by your PCP and they're like, okay, stick out your tongue and say, and then move your tongue from side to side, they're looking at a few different things, but one of them is your cranial nerves. So that's all 12.
And what mnemonic did you guys learn?
Oh man, I know there was mountains involved. I'm trying to remember. I'm like, I don't know. Now I just know them. But
I know mine. It was to take a flight. Very good vibes and highs.
Oh, okay. That's good.
I haven't heard that one. I remember now. On old Olympus's tiny top, a Finn and German viewed some hops or something like that. I can't remember, but I was like, went along that way because it's, and it, helps you remember, but whatever gets you through when you're in school and you're learning.
Sarah, what was yours one more time?
It was to take a flight. Very good vibes and highs.
I like it. That's actually probably my favorite one that I've heard.
Yeah.
If you do look it up though, there are some rated R versions of that. So let's zoom in now on cranial nerve 7, the facial nerve. What is it responsible for, Sarah?
So the facial nerve does a few different things for us. The kind of main thing that we think about is the muscles of facial expression. So there's a little bit of difference in how we count the muscles. There's about 25 muscles on each side of the face. It's a lot of different muscles on the face. And these muscles are what allows us to do things like close our eyes or smile or wrinkle up our nose or take a sip of water. So those muscles of facial expression. It also has some other accessory roles, though. It does innervate a little muscle deep in the inner ear called the stapedius muscle. And that's a muscle that helps dampen down when there's a really loud sound. So some people after paralysis will notice that they have what's called hyperacusis. Loud sounds are really bothersome to them. It also innervates the stylohyoid muscle and the posterior belly of the digastric, which are not our main swallowing muscles, but they kind of help out with the swallowing process. And then it does have about a third of its fibers are sensory. So while Carly gave a great explanation of the cranial nerves, the touch sensation of our face is innervated by the trigeminal nerve. There are some sensory aspects to the facial nerve, and it does the lacrimal gland, so it does part of your tears. It does some of your mucus glands in your nose, some of the salivary glands, and then also the taste buds, but just to the anterior 2/3 of the tongue. So typically people will talk about their taste being distorted, not absent. So a lot of times people will talk about maybe a metallic taste, or there are certain things that just taste funny to them, but there's still some preservation of some taste.
And can we also now talk about what diagnosis or condition might we see, or I should say diagnoses or conditions that we might see, maybe the more common ones that can involve the facial nerve and contribute to paralysis or partial paralysis? How would this patient look when they come in, and what is the general prognosis for each of these conditions?
Yeah, I can start and then I'll tag Sara in so I can share at least what I saw the most commonly. So Bell's palsy is probably the most common condition that I would see in the clinic. And with Bell's palsy, there's a viral infection and it's actually interesting. The hypothesis is not, we still have a hypothesis of why do people get Bell's palsy. It's a little bit unknown exactly. But, there is some sort of virus or something that causes inflammation or irritation to the facial nerve. And because of where the facial nerve is, the way it runs through a really narrow space here. And there's a bony structure that it's running through, and it's not very wide. It's kind of a small tunnel. And so if that nerve gets inflamed at all and it starts to swell, it can give itself damage sometimes from that process of irritation and inflammation. So Bell's palsy is one, and this can be precipitated by, stress as well. Sometimes stress that kind of activates this virus. So stressful times, pregnancy, we'd see sometimes after different, like the COVID vaccine, we saw increased incidence of Bell's palsy. So that's some examples of things that I would see clinically. And then other things that I saw a lot of the time, Ramsay Hunt syndrome, which is similar but a little bit different. And we'll talk about that maybe a little bit later. And then I saw a lot of actually individuals with partial facial paralysis from having a tumor in the parotid gland within this part of the face. So the parotid gland is here, and it's, the part of the facial nerve will run right through it. And when the tumor gets resected, sometimes that nerve can get damaged. So that's what I saw, I think, the most commonly. But Sara, I know you mentioned acoustic neuroma or vestibular schwannoma, and they're the same thing. And you can maybe speak to the things that you saw.
Yeah, so we definitely saw the same diagnoses that you're talking about, Carly. But we also treat a large population of patients with acoustic neuroma tumors or vestibular schwannoma. It's two different names for the exact same thing. And typically what we'll see is if they have a surgical resection of the tumor or radiation to the tumor, there can be a little bit of collateral damage to the facial nerve as well. So I've really never seen our surgeons cut or transect the facial nerve. It's that there's just postoperative swelling. And like you were describing with the Bell's palsy, there's nowhere in that bony channel for that swelling to go. So the patient will develop a facial palsy as part of their postoperative healing process. Honestly, usually day 2 or 3 post-op, because it takes a little bit of time for that swelling to build up in that area. So we'll see acoustic neuroma, sometimes facial neuroma. So if the tumor is not originating from the vestibular nerve, but rather the facial nerve, we'll see that. Trauma. Unfortunately, we do see after car accidents or ATV accidents, if there's a temporal bone fracture, they can do damage to the facial nerve. Some of the other kind of less common ones, things like Guillain-Barré, there are certainly congenital causes of facial palsy that we'll see. Lyme disease is out there in different regions of the US. So we see some of those, but I'd say primarily Bell's palsy, Ramsay Hunt, and acoustic neuroma.
And then prognosis, I'm sure, varies across the board here. Can you give us some insight there?
It does depend on the diagnosis. So we know, for example, the prognosis with the Ramsay Hunt is worse than the prognosis with Bell's palsy. we know that in a case of trauma where the nerve is severed, that's going to have a poorer prognosis than if the nerve is intact. So there are some things that the diagnosis can tell you can lead you to the prognosis. But when we are discussing with our patients what we think their prognosis is going to be, we're really trying to deduce how severely the nerve was damaged by whatever process damaged it. So we look back at just your nerve injuries, and you can look at those grades of nerve injuries. If you suspect that it's a grade 1 or 2 nerve injury, meaning if you're a patient and you haven't looked at this nerve injury stuff in a while, this might be a lot, but I'll make it real simple. If the nerve was damaged, but the protecting sheath around it, the endoneurium wasn't damaged, then the nerve is usually going to heal up and the patient's going to recover nicely. And so that's what we see in about 70% of Bell's palsy cases. So I'll describe this to patients as if you take a garden hose and you kinked it and water can't flow through it, and then you unkink it and water is going to start flowing through again. That's what we see with Bell's palsy. And those are the patients who will describe that they had maybe 2 to 3 weeks of a paralysis or a palsy, and then they went back to feeling really normal. It's almost like they never had it. Where we really specialize as therapists is the grade 3 and 4 nerve damage. And so those are the patients where the endoneurium, that protective sheath around the nerve, was damaged. And so when the nerve comes back, it will heal. It typically does heal, but the way I describe it is it comes back, but it just comes back differently than it left. And so we're left with one half of your face that just doesn't match the other half because of the atypical nerve healing. And that's just going to happen in cases where the nerve underwent more damage during that disease process.
Yeah, I love that, Sarah. I love the kink in the garden hose explanation. I'm gonna use that, and I'll credit you. But thinking about the thing that I think is cool is that your nerves in your what we call your peripheral nervous system, they can and do regrow, but there can be roadblocks, right? So when there's a really large amount of damage or trauma, it's almost like this little nerve that's trying to grow again. If it has an obstacle in the way, maybe there's scar tissue or something, it can't go back exactly where it wanted to before, but it might grow to somewhere slightly different and try to innervate other muscles in the surrounding areas. So I think, though, if you have that sheath surrounding the nerve, that's almost like having a highway straight to where, the end goal is. So that nerve, that's why the healing can be better, is because it just has a straight path and it knows exactly where to go.
Now let's also dissect a little bit more Bell's palsy and Ramsay Hunt, because I do feel like most of the population has probably heard of those terms, but probably doesn't necessarily recognize the differences. Sara, you mentioned prognostically a little bit of a difference there. What about other features?
So Bell's palsy, the definition of Bell's palsy is facial palsy of unknown origin. So really, they suspect it might be viral, but they really don't know. They do think it's probably, like you were describing, Carly, inflammation, edema around the nerve. And that's different than Ramsay Hunt syndrome, which we know is caused by the shingles virus, by zoster. So that's one difference, is that we really know what causes Ramsay Hunt, and Bell's palsy, they're not entirely sure. Bell's palsy is more common, so it is gonna occur more often than Ramsay Hunt. In fact, many people, before Justin Bieber had it, many of our patients said they'd never heard of it before. So I was actually very happy he came out and talked about and gave a name to the diagnosis. I think it really helped empower some of our patients to say, oh, I had that as well. So Ramsay Hunt is this shingles virus. The patients with Ramsay Hunt are typically going to have more severe nerve damage. So more likely to have damage to that kind of protective sheath, more likely to have an abnormal healing pattern. They also are going to often have damage to the surrounding cranial nerves, which is a big difference. Usually Bell's palsy, there's just one nerve involved. It's just going to be the facial nerve. With Ramsay Hunt, we'll often see the patient present with at least 3 cranial nerves involved. They'll usually have loss of hearing on that side, the cochlear part of cranial nerve 8. They'll have usually a sudden onset of dizziness, so the vestibular loss of cranial nerve 8. Sometimes they'll even have trigeminal involvement and have numbness on that side of the face. So Ramsay Hunt is usually a little bit more severe than a Bell's palsy.
If you've ever noticed that certain lighting or screens just feel like a lot,
especially if you're living with migraine, you're going to want to check out Avilux glasses, which work to absorb specific wavelengths of light and may, as part of a healthy lifestyle, help people living with migraine. Just to be transparent, we partnered with Avilux on this, and if you want to check them out, we'll link them in the show notes. And by the way, you can use the code DizzyReset for $25 off. All right, let's get back to it. So let me ask you this. If I had a diagnosis or I presented as if you were suspecting facial nerve involvement, what does your assessment look like? What functions are you looking at on your examination? And maybe I can play the role of a patient for anyone watching on YouTube, and you guys can take me through a little bit of your assessment. Carly, do you want to start?
Sure. Yeah. So my assessment starts from the minute that we start talking, right? So I'm observing and seeing how, is there anything discernible that I can pick up in terms of facial differences from side to side when your face is at rest and when you're speaking. And I'm just looking to see, what do I notice? And I'm kind of jotting notes down. Things that I really want to ask about in my subjective. I want to know, how long has this been happening and what has the course of care been like so far? So if it's something that seems like it might be a Bell's palsy or a Ramsay Hunt, there are different, medications that are sometimes very helpful to get early, that can be helpful in recovery. So I'm wanting to know, have you done that? Have you seen other provider besides me? And a lot of the time the answer is yes, because I will say the sudden onset facial palsy where the face is drooping can feel so scary. And so patients often do end up in the emergency department and do, as I've seen more and more, are getting the right kind of care, which is great. But so then I'm asking about those things. I'm asking about your eye. I want to know, because sometimes when we see facial palsy and you lose the ability to close your eyes fully, I want to know, have you noticed any dryness, any itching, any tearing, anything at all, so that it's helping me figure out where I might need to spend time educating. So I want to know what you're doing there. And then I get a general sense of like what you can and can't do. So maybe, are you having any difficulty with eating? Are you having difficulty with drinking and things like that can feel different when one side of the face is not quite working the same. So that's, I think, from a subjective side, the questions that I'm asking and what I'm looking for from observation. And then I'll have Sara talk about maybe the more objective assessment, what you're actually doing, and any other questions too that you want to make sure that you ask.
Yeah, I think I very much am in line with what you're talking about. The only other thing, and I'm sure you do this as well, is there is, and we'll probably talk about this more, but there's a really big psychosocial component to facial nerve disorders. And so I really want to know how patients are doing, like just overall, how are you doing? Because sometimes even more so than our vestibular disorders, your face it's out there. And we always tell people that facial nerve disorders, people will come in saying, I didn't think I was vain. I don't know why I'm so upset. And every time we'll tell them, your face is your thumbprint of your soul. It's how you communicate with the world around you. And you now have a disorder of communication. It would just be as if you couldn't speak. And so do not think about this as a vanity problem. This is truly impacting how you're interfacing with the world. So we just try to normalize all of those big emotions up front, because it can be a lot, and it's a lot for patients to carry. But looking in their objective, we're really looking at the face both at rest and then in dynamic motion. So the facial muscles are a little different than our body muscles. Actually, they're a lot different than our body muscles, to be honest. They have some unique characteristics, but one is that they're always on. So we carry resting tone in our face, which is what gives us the contours, the shape of our face, our creases, the shape of our jawline, things like that. And so you'll want to look at initially, if you just draw a line down the patient's face, what does the right side look like compared to the left side? And that can help give you a lot of insight about where that patient might be on their healing process. So to not get too deep into it, but in the beginning, when a patient's in a full paralysis phase, their face would look drooped, meaning the eyebrow would be low and drooped, the eye would be gaped open, their cheek would be hanging down, and the corner of their mouth would be dropped. So that would be something you'd be looking for in the palsy phase. And then if I was going to go through some motion, so Abby, I'll have you move. I usually just start at the top and work down because I like to just stay organized. So after I had looked at your symmetry at rest, which is very normal. And we also have to remember that there's small amounts of asymmetry in everybody. So yours
I
is
was
very
going to
normal.
say, I wish I was symmetrical. I am not symmetrical, but yes.
So join the club because nobody is. So we know that. So then we would start with just simply raising your eyebrows like you're surprised. Yeah, good job. Relax. And we might do that a couple times so I could appreciate the quality of motion. Good. Now I want you to gently close your eyes, just a soft eye closure. Excellent. You can open back up. Now I want you to squeeze your eyes tight. Good, and open back up. So sometimes people can't close their eyes gently, but when they give it a good squeeze, they can. Now I want you to wrinkle up your nose like a bunny. Good, relax. Now I want you to smile with a closed mouth. Good, relax. And then I want you to do a smile with an open mouth. Good, relax. And then pucker. Good, relax. And then I'll have you try to show me your bottom teeth by pulling your bottom lip down like you're trying to get food out of there. Good. And then open your mouth wide. Good. So I'm just checking kind of some of our basic movements. And if you're watching, I'm demonstrating because that's just my natural thing. I'm going to demonstrate for the patient what I want them to do. So we're looking at the quality of motion between the two sides, whether the affected side is moving less, or if we're later in recovery and it's actually overactive, that's the sort of thing that we're looking for during that motion assessment.
Love that. And I think that will be super impactful for people watching to be able to implement this into their examinations. Now, out of all the conditions that we've talked about, which we kind of already touched on this a little bit, but which conditions also tend to involve dizziness, vertigo, imbalance, and why?
Yeah, that's a great question. So I think the first, Ramsay Hunt is the first one that comes to mind. And it's actually something that I will always ask, even if a patient's coming in with a Bell's palsy diagnosis, I'll still ask, have you had any change in your hearing or dizziness or imbalance? Because sometimes they have, and it actually maybe is not Bell's palsy, it may be Ramsay Hunt. And yeah, so that's the first one for sure. And it just is the proximity of the shingles virus and what's happening. And it's just those cranial nerves 7 and 8 are very close together. And because of their proximity, sometimes you see, and same thing with a vestibular schwannoma, a tumor that's growing there because it's so close in that space. That's why they often can be impacted together. So I think the vestibular schwannoma / acoustic neuroma, I can't pick one. I don't know why because I'm like, I got to say both names, but those, and then Ramsay Hunt, trauma. And then I will say I had a few patients that had meningiomas, which is a different type of cranial tumor. And again, just where it was growing, it happened to impact both of those as well.
So it's all about location.
Location. You got it.
Now, we also talked about how most people, by the time they get to you, they've already seen some healthcare providers. Ideally, who should be on this patient's team, Sara?
So in the ideal world, a patient would get seen very quickly because like Carly was alluding to, there is some research that says if a patient has specifically Bell's palsy and they can be put on steroids, if they're appropriate for steroids, within the first 72 hours, that should help their chances of a better recovery. So we would want people to be seen in that very acute window by whatever provider they can get into. So their primary care and ENT, sometimes it's the ED because oftentimes people may be concerned they're having a stroke because of the paralysis on one side of their face. So that early intervention is very important. The other person I like for patients to see early on is their eye doctor, because as you mentioned, if the eye is not closing all the way, not blinking, there is a big risk for exposure and dryness or corneal abrasions. So getting in to see the eye doctor early is wonderful. We would love for patients to get in to see us right away so we could get them established and start some really wonderful education and get them going on hopefully a journey of recovery. That often doesn't happen. Honestly, we just published a paper recently looking at some longitudinal data out of our clinic, and we found the average time for patients to get established in our interdisciplinary clinic was about 7 years after their onset. There is and we might touch on this later, but there is a little bit of I think still a barrier here. And I think this podcast is a wonderful opportunity. People don't know that there is excellent care for patients dealing with facial palsy. So sometimes there's just a lack of referrals. But if I could create a dream team, it'd be an eye doctor, it'd be a trained therapist, and it could be a physical therapist, speech therapist, occupational therapist, whatever discipline, as long as they're trained in treating the facial nerve. I'd want a counselor or a social worker. Like I said, there's a big psychosocial impact. And then sometimes ENT, sometimes neurology. It depends what the etiology of the diagnosis was, but definitely also your facial plastic surgeon, your kind of trained facial plastics physician, along with those other people. That would be kind of my dream team. Did I forget anybody, Carly?
No, I think that's perfect. And that was like, I think we had an ophthalmologist, and we also had just your traditional eye doctor that you're like, so we had both of those things, because sometimes depending on what's happening with the eye, there are things that you need from ophthalmology. Other times you can just see, your more traditional eye doctor. And we wanted a psychologist so badly, but we had a hard time finding a psychologist to come to our clinic consistently, just to provide that psychosocial support with this huge shift in perception of self.
We're going to get to that in just a second, but I'll just throw it out there that you want Sara or Carly on your team as well. That's the physical therapist you want on your team.
We're ready and willing to help. And I wish that, and this is a PSA, everyone out there that's listening, please tell your friends that if they are diagnosed with Bell's palsy and they're told, okay, here's your discharge instructions, you're going to get better in 3 weeks, they can absolutely seek and should seek care from someone right away. If like any rehab therapist who knows and can treat facial process, because even in that waiting period, there are things that you can be doing just to help you feel better during that time. And like, why not feel a little bit better if you can?
Especially from this next subject, we're going to talk about the psychosocial subject, because it's not just the appearance, it's what it's doing internally to you, what you're thinking, how you're communicating, how you're connecting with others. I mean, just so many things that maybe you don't think about right away. And this often rings true for people who are dizzy as well. But let's talk about specifically for people who experience facial paralysis. What can happen to their confidence, their sense of self, their communication? Let's get a little bit more detailed now, Sara.
Yeah, so I already alluded to this, because it is just a huge part of this type of care. And I do think as therapists and vestibular therapists, we're pretty tender people. And I hold these sessions are very tender sessions to me. People are very vulnerable. It's their face. It's very, very important. And I think just up front, it's important to know there is anecdotally, but there's also research to support this, that the amount of paralysis does not correlate to the amount of psychosocial impact. So a patient may have what you perceive as a very kind of mild palsy, and they can be extremely affected by it. And the other is true too. You might see a patient that has a very severe palsy, but they really doesn't affect them that much. And so I think that it's important that we don't make assumptions, that we talk to our patients and we ask those good questions. But we kind of talked about it already, but the communication aspect. So we forget that most of our communication is nonverbal, and we're communicating almost all the time. If you're watching this podcast, somebody's talking, we're nodding, we're smiling, we're making very small micro expressions that say, I hear you, I understand you, I'm happy with what you're saying. And if you lose the ability to do that, it is truly very limiting for people. There's research showing that it's impacted people's ability to get jobs. People make assumptions on their intelligence, even though there is no cognitive impact with any of these conditions. But people will make assumptions. And there's just been a lot of research in this world about the psychosocial impact in terms of people feeling isolated from their community. So it can be, I don't think there's a one size fits all approach to how to address this. I love bringing in a counseling partner to help. But I do try to talk about it and normalize it and help people understand that it's okay to feel this way about it, because it can be a tremendous impact to patients. There are support groups out there, which I think can be nice. So people don't feel alone in this journey. But there's a lot of work to do in this area.
Carly, do you have anything to add to that?
No, I agree completely. And earlier when Sarah, when you said that like our faces are sort of expression of our soul, you gave me goosebumps because it's true. And it really, I just remember, and I'm recalling, a group of, and a pretty large number actually of my patients with facial paralysis in early COVID, when the mask mandates first came out, they were stoked. They were so happy because they're like, you can't tell. And I feel like now everyone sort of experiences a little bit of what I experienced, where it's kind of hard to read people. You can't quite read someone's expression quite as well when they have a mask on, and that's how they feel without the mask. And so I just remember that being really striking to me about, they were like, oh no, this is great for me right now while I'm healing. So yeah, definitely. Yeah.
Thank you both for sharing that. I think the more that we talk about these things and spread awareness and give people an outlet of something to listen to, like, oh, I'm not alone actually, and someone does know what I'm experiencing, I think that part is so, so beneficial in the healing process. So thank you both for being here today to spread awareness. Carly, can you talk to us a little bit more about some daily functions? And again, this is something we've kind of sprinkled in here and there throughout this show so far, but can you talk about some daily functions that people might take for granted until facial paralysis strikes?
Yeah, absolutely. There are a lot of them in short, but so thinking about like when you first wake up in the morning, you might get up and you think about, I'm going to brush my teeth. Well, you need some of your facial muscles to maintain closed lips so that you don't spill toothpaste, right? So you can have spillage there. So that's, step one. Then thinking about when maybe you want to have a sip of water, you're going to have breakfast, the same problem can happen where it's hard to maintain that lip closure. So food and drink might be spilling out. So a lot of my patients did not like going out to eat, did not want to eat in front of other people, wanted to be by themselves, right? And then that has a social impact where all of a sudden that's changing. Speech, where it's harder if you think about, if you have part of your face that is either sagging down a little bit or is very tight, speech can feel difficult and can feel exhausting. And so for some of my patients where maybe I had someone who worked at a call center, and so they were speaking all day and they're like, I'm exhausted. Like my face is just hanging by the end. And so there are things that we can, do to help that. But speaking, taking photos is a big one. That's always, they, try, and that's sometimes a therapy goal of figuring out, okay, let's figure out like our goal is having a small social smile for pictures, and just trying to think about that. But a lot of events, right? They're like, okay, like let's all get together and take a picture for, any sort of gathering, event, milestone day. And that can be really, really big because it's memorializing a really hard time for somebody, right? So I think pictures was always a really big one. And then I had a few patients. So like, thinking about when you go out in the sun and it's bright and you need to squint a little. Sometimes it's hard to close your eye after facial process. So you can't. And so it hurts your eyes. I had a patient who had a hard time, was not going out to exercise because the wind actually would bother. And so we figured out, okay, you can wear this type of sunglasses to protect from the wind a little bit, but there's so many things, and there's so many more than that too. And this is just the tip of the iceberg, I feel like.
Even just sharing that though, I think for anyone that hears this, it's so validating. Like, of course there's psychosocial involvement here because there's likely some isolation happening because of all these daily functions that happen typically so automatically that don't anymore. So I think there's a lot of crossover there in the dizzy population as well again. If you're listening and wondering, okay, what do I actually do about this? Well, we created the Dizzy Reset with you in mind. It's our online program and community that gives you a clear place to start with support along your step-by-step journey. You can check it out in the show notes, and don't forget to use the code TALKDizzyToMe for 40% off your first month, because life's too short to stay dizzy. All right, let's get back to the show. Now, I have to ask this question, but I think I already know your answer that it depends, but can we talk about treatment? What does it typically look like? How does it change depending on the underlying cause, Sara?
So treatment can look like a lot of different things, honestly, because it depends on where the patient is in their journey when they come to you. So like Carly mentioned, when the patient is experiencing a paralysis, so this would be really early on in the palsy, really at that point, we're trying to make the symptoms better, make them more comfortable. So it might be eye management, eye protection. Sometimes we'll do some taping to support the cheek so that way they can talk a little bit easier, make modifications for how they can eat and drink. There is sometimes a misunderstanding that we can make their face move again, but that's not true. We have to wait for that nerve to heal, that nerve to hook back up. So I'll give patients the analogy of a lamp that's been unplugged from the wall. You can turn that switch on the lamp as many times as you want, but until it's plugged back in, that light bulb's never coming on. So early on, we actually don't encourage them to try to move their face a lot because we don't want to train bad patterns. I just say, let it heal. And I say, take care of you, eat well, sleep well, have a good diet. We try to talk about just taking care of yourself in a good healing phase and making their face as comfortable and symmetric as possible with whatever stretches to the other side, taping to the involved side, eye management, things like that. As if they then go from there to a full recovery, then that's wonderful. That period of care may be quite short. That might just be weeks or a couple months. What we typically tend to see more of is our patients who had, and you mentioned the kind of highway analogy, I use that too. When the nerve heals, but the protective walls got damaged, I'll explain it like a highway where all the lane dividers got erased. So you have cars kind of driving every which way. So when that happens, the facial nerve, it heals, it comes back, but it comes back differently than it was. And typically what we see that present with is rather than a face being droopy, it's actually tight. So the cheek is pulled up, the eye is squinted, and they're kind of stuck in this really tight position. And they still have a lack of motion, but it's not because their facial muscles aren't working. It's not because of paralysis. It's because everything's too tight to move. Everything's moving at the same time and they're fighting each other. And so that's a phase of facial nerve healing we call synkinesis. And if a patient's in synkinesis, that's where I really recommend that they try to get hooked up with a specialist because it's a little bit more tricky to treat, but it is doable. And that care can truly go on for years. I typically will see our patients pretty infrequently, maybe once a month, once every 3 months, once every 6 months. And this is where the interdisciplinary team is very helpful because we'll do therapy. Botox can actually be quite effective because we know Botox calms muscles. That's why people get it to try to quiet out wrinkles. We don't want our muscles to move to create wrinkles. Well, if you have muscles that are overactive, so I'll give a really basic example. If you're trying to smile and you're smiling, but also your frowners got hooked up when the nerve rewired, it hooked to both your smile muscle and your frowner muscle. You're trying to smile, your frowner muscle is trying to pull down, you're activating both at the same time. If we can either train you to keep your frowner quiet, or if we need to Botox it to turn that muscle off, relax it, then what we've done is we've just allowed your smile muscle to come up more normally. So there are a lot of things that can be done. Unfortunately, a lot of patients are told there's nothing that can be done. So that can be a little bit frustrating. So the recovery, it's a long answer. It depends on where they are, and it depends on what type of healing they're experiencing.
Something I want to highlight here that you said is I tell them to take care of themselves, whatever that looks like to them. And again, I think there's parallels to the dizzy world because sometimes with the isolation and with the psychological impacts that these conditions can have, you lose yourself in ways that don't need to be lost. Like if you enjoy painting, you can still paint. Why are we not still painting? I know that there are things that we lose in isolation that are so supportive of healing. And I like to encourage people to remind themselves who they are as a foundation to healing. We don't want to forget that part. So I'm glad that you said that. And then also taking care of yourself, like you said, sleep and hygiene and hydration and the foods you're eating and the people you're surrounding yourself with, the messages you're listening to, all of that has a role. Carly, is there anything you would add to the recovery?
No, I think that the other piece, and I know Sara does a ton of this, and I do too, is the education piece, right? And setting up realistic expectations, because it's a less well-known condition, I think, then people turn to the internet, right? And they're looking and they're seeing what's there. And you either see, oh, it's going to go away in 3 weeks, or maybe that's even what they were told in the ED. And then when it doesn't, if it doesn't, then the expectations are like, well, what? And then, so I think that's the piece that I wish I could change, is that I wish expectations could be set slightly differently and the education provided slightly differently in that acute phase, so that people know, oh, there are things I can do, and this is what I do if things aren't progressing in the way that, they should be. So, but I think education. Oh my goodness.
That's an excellent point. I mean, education is treatment. I think that's true in the vestibular world as well. But, and you know this, Carly, we spend an incredible amount of time trying to help patients understand, because it is such a rare condition. Facial palsy itself is not that common, but synkinesis, the kind of abnormal healing of facial palsy, is quite rare. And so there's just a lot of education that goes around that.
Can you tell me, Sara, the topics that you usually cover? Like, I know when I have an eval, there are certain things I like to hit depending on what they're presenting with. I'm sure you both have the same for this patient population. What topics are those?
Yeah, so I mean, it might vary a little bit based on what the patient's asking about or talking about, and it depends on what phase they're in, but I will almost always cover the structure of the facial nerve. So I'll show them a little telephone cable and how there's lots of individual little fibers inside of that to represent the axons. And there's a little protective sheath around that and a protective sheath around the nerve. So I'll try to explain that no two injuries are always the same. So they might say, well, my neighbor had Bell's palsy and it went away in 2 weeks. Why is mine still here? So I'll try to explain the structure of the nerve. I have a little graphic where I explain the different phases of nerve injury for the same reason, to kind of explain why presentations might be different, why our expectations might be different. I have some pictures. There's a lot of graphics and pictures of the muscles. We'll go through what do normal facial muscles do? What do we expect these muscles to do? See how the arrow on this muscle pulls up. It's because this is the muscle that raises our eyebrow. It's the only muscle that raises our eyebrow. There's a couple of muscles that pull our eyebrows down, and I'll show them these different movements. And then we'll talk about some of the differences between facial muscles and our body muscles. So I'll try to hit some of the big ones. Like, there's a lot of them. For example, there's a lot of them in a really small space, which is not how the rest of our body is set up. And there are no joints in our face. So one of the biggest things I want them to understand is that in the face, more strength does not equal more function. We don't need your muscles to be stronger. We need them to be more coordinated. So if you imagine the skin almost like a piece of fabric, and these muscles can pull that fabric in really an infinite number of directions. We're not training one muscle to strengthen in a certain plane. We are trying to train very small, delicate muscles to move in these micro expressions, these very small movements. And so I'll tell them, I don't want you going home and trying to strengthen your facial muscles. We don't need them to be stronger. We need them to be more precise and more controlled. So trying to explain the differences between how our face is designed to move versus our body muscles. Because like you said, Carly, they'll find a lot of things. Unfortunately, there's some good information online. There's some bad information online. And what we see a lot of is that people will try to do all these big exercises. They're really trying to get their face to move. And unfortunately, those are often counterproductive.
I like that you educate on that piece too, because I think that would be maybe a misconception or common myth that, oh, I just need to work harder at this and get this stronger, versus what you said, more coordinated. That makes so much sense. Is there anything you educate patients on that they should maybe stop doing because it impacts their recovery, or maybe certain conditions that could impact their recovery? Carly, is there anything you educate in that regard?
Yeah. So the first one is what Sara was just speaking about, the big mass movements of trying to just like get it to go, right? And do these really big facial expressions. And I'm like, please stop doing that. Like, that's not going to give you the results you want. And then we'll explain exactly why, like what Sara was talking about. It's way more about coordination and not about strength. As the healing comes, the strength that's needed will be there. It's more about like having those muscles work together in a coordinated way. the right way. So that's the first one. There are all manners of things I feel like I have had to kind of say, no, there's no, and like, I think it depends on what, what is available on the internet. I think there's some controversy about using electric stim. I know I actually was in school, in PT school, doing direct current stimulation with one of that was kind of taught to me as like, this is what you should do, which it's not, and so I think patients will come in and ask, is there anything to make this faster, right? So they want to know, can I use electric stimulation to enhance and stimulate my muscles? And in very select cases, it may possibly be appropriate, but the research is not there yet to say yes for sure. And like, because there's such a mix of results, we can't recommend it. So that's something that I'm like, okay, probably not. But are there instances? Yeah, maybe. But like, for the most part, no. That's something that I'll have to educate patients about, and it tends to be a lot of those things. Will CBD lotion on my face help this go a bit faster? It's a lot of things about trying to speed the process up, I think, which totally understandable. But yeah, so education about that no, we just have to let the nerve heal. And the best thing you can do is take care of your body and do things that support healing. And then thinking about, are there, you'd asked a little bit about like other things that can impact healing. Well, thinking about, yes, if someone's a smoker, I am going to maybe bring that up and have a conversation about that, because smoking definitely can slow the healing process. And so we'll talk about that. The same thing with the presence of diabetes. If it's uncontrolled, I might bridge that conversation and see if someone's ready to talk about that, like maybe getting their diabetes a little more well controlled, because that is something that also can impact healing. So those are things that I often will kind of include in my education, and then general just sort of wellness based recommendations that support healing. So I think those are the things for me.
Great. Now, already brought this up too, but misconceptions, myths. Tie this up nicely for us in terms of what people often think versus what you want them to hear, Sara.
So I think there's a couple of big ones. One is that there's nothing you can do. So people are told you have Bell's palsy or whatever diagnosis are given Ramsay Hunt. It's either going to get better in 3 weeks or it's not. And that's kind of all they're told. And so I think that setting up that early education that there's different degrees of nerve injury. On day one, we don't know your degree of nerve injury. That doesn't reveal itself until time has gone on for us to see how quick is the recovery. We know that the sooner you start to recover, and by soon, I usually mean within starting to show any signs of healing within the first maybe 2 to 3 weeks, that's actually a great indicator. That means you might have a pretty good recovery. If you are going a bit longer, maybe it's several months before we start to see movement, we still expect you to get better. I think that's another point that should really be out there, because if somebody has a paralyzed face for 2 or 3 months and they were told it should be 2 or 3 weeks, then they think, what do I need to be doing to make this process go faster? But there's nothing you can do to make the process go faster, because we're waiting on the nerve to heal, and it can only heal at 1 millimeter a day. So there's just not much you can do to change that rate of healing. And so I think that if we could educate people early on, not just to say it's either 2 or 3 weeks or nothing. Look, this is what we expect. It depends on the degree of nerve healing. This is what this process might look like. We need to take care of you early on to help you through this very hard time where your face isn't working. And then we are going to follow you through this journey. And if you heal up and go back to very normal function, lovely. If you don't, we have this team in place. We'll get you a quick referral there to get you on to a specialist facial therapist and a facial nerve team. So that's one. That's a dream. I don't know that's going to happen, but some better education early on, thinking there's nothing they can do. And then the other one is like you already were mentioning, Carly, some of those things out there. I think that time of paralysis, those first few weeks, those first few months, is a very vulnerable time period. And so, and I completely understand. If it was me, I know I would be willing to try literally anything. But I think that there's a lot of kind of false advertising. There's a lot of misinformation out there. And so just understanding a little bit about what happens with the nerve and that we're waiting for it to heal. And that very likely if somebody's promising a perfect quick fix, if that existed, we would all know about it. So just kind of being mindful that that nerves heal, and there's just not much externally we're going to do to change that healing.
Again, such a parallel to dizziness. Nothing irks me more than if I get targeted for an ad that promises their dizziness of 10 years will be resolved in 2 days.
Right.
Like,
if that existed, we would have already told you about it.
and also
keeping it, that's the thing,
you're
Right.
preying on a very vulnerable population of people too. And it just makes my blood boil.
And we talked about this a little bit, but pregnancy is a big risk factor for Bell's palsy, 3rd trimester and the first 10 days postpartum. So talk about a vulnerable population. You've got a hormonal exhausted mom. So it's just, like I said, it's a very tender time. And I think there can be some very bad information out there.
Mm-hmm. Mm-hmm. Now, as we close out today's show, Carly, I want to hear from you first. What message would you like clinicians to walk away from? What takeaways from today's talk? And what message do you want people currently experiencing facial paralysis to hear?
So I think for the clinicians out there, if you don't treat facial paralysis yet and you heard this and your interest is piqued, there are some really great education courses to take and resources out there, and we desperately need you. So please do. So that's the first thing I'll say. The second thing is, if you hear this and you're like, this is maybe not my jam, you can still learn enough to be able to help a patient. I'll never forget, I had a patient, I was just working in acute care. I picked up a shift and was doing bedside care. And I happened to be a therapist who treats facial paralysis, but that was not the context that I was seeing this patient. And she just had a tumor removed and had facial droop. And she ended up having an episode where she stood up and she ended up passing out. And it's because she didn't have any water, because she was spilling water and she didn't know how to drink. So you, as a therapist, you can at least learn a little bit and screen for this so that you can help even if you're not going to be the person to treat, to point someone in the right direction, because there are things to do and there are people that treat this. So I want to encourage you to at least know enough to screen the way you might screen for other conditions. Screen for any facial weakness, and then help get someone the help that they may need. And for patients out there, we are here and ready to help. If you are feeling like you are stuck, or you're feeling like you do want support, there are great resources out there, and we can link some in the show notes of maybe places to start. But you're not alone, and there are people that do know how to help you get to a place where you're maybe feeling a little bit more confident, things maybe feel a little bit easier. There are things that you can do. You're not just stuck.
What about you, Sara?
I echo everything you said, Carly. Beautifully spoken. And so to the therapist, again, it's not going to be everybody's jam to treat this. It's a very unique condition, and that's absolutely fine. I think it's understanding when a patient might benefit from seeing a specialist, just knowing and understand. Hopefully you heard in this talk that the facial nerve, the facial muscles, the way we treat the face is very different than the way that we treat other conditions. And so if you're saying, I've never done it before, but I think I can just figure it out, maybe just take a pause, do a little bit of research. We'll link some resources in the show notes to either educate yourself a little bit more about the specifics of the facial nerve, or maybe pass that patient along to somebody in your area. And to patients, again, like Carly said, you're not alone. There are a lot of people out there who have devoted their careers to learning more about this condition and making every gain that we can in science. Although I think it's a science and an art to treat this, but there are a lot of people who are working really, really hard at this. So if you feel like you don't have any resources or you don't have any support, we'll put some places in the show notes, some websites and some things that you could maybe start investigating, because there's a lot out there now, and sometimes it can be hard to find, but hopefully we'll help you find it.
I love it. Both of those messages were gold. Sara, do you have a webinar or something coming up for clinicians on this?
I do. Thanks for asking. It's going to be in March. We haven't quite announced the date yet. So if you don't follow us, and we'll put this in the show notes too, our social media handle is @Dizzy Diagnostics. So we will be putting out lots of facial content. I've made, I think, an incredible PDF resource that is about 20 pages. But it's got tons of information in there, and that will come with the webinar. And I'm going to do a webinar kind of breaking down some of the things we talked about, but just a little bit more targeted to clinicians, how to assess and how to initiate that treatment. So that should be coming out next month.
Perfect. And Carly, where can our audience find you?
Right on the Balancing Act Rehab webpage, everyone. And you'll see me on the socials sometimes as well, just with Balancing Act Rehab. So I'm there and I'm ready and would love to work with you.
And also, I'm just going to put this out in the universe. I think one day we'll have something specific for patients in terms of a program or online community. Hopefully, I'm trying to convince these two ladies to join me in doing that. So thank you both for sharing your knowledge. You're both gems of physical therapists and gems of human beings. Thank you for joining us on Talk Dizzy to Me today. And thank you, audience, for listening.
Thanks for having us. This was so fun.
Thank you so much. What a wonderful opportunity.
This podcast is provided for informational purposes only and is not intended as a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified healthcare provider with any questions you may have regarding a medical condition.
The content of this podcast is based on general knowledge and information available up until the recording of this specific episode. Medical knowledge and practices may evolve over time, and new information may emerge that could change the understanding or treatment of vestibular dysfunction. It is important to consult a qualified healthcare professional for the most up-to-date and personalized advice.
The information provided in this podcast is meant to complement, not replace, the relationship that exists between a patient and their healthcare provider. It is intended to empower patients with knowledge about vestibular dysfunction and its management, but individual cases may vary, and treatment approaches should be tailored to each patient's unique circumstances.
By listening to this podcast, you acknowledge and agree to the terms of this medical disclaimer. The organizers, presenters, and creators of this podcast are not liable for any actions or decisions taken by individuals based on the information presented herein. Always consult with a qualified healthcare provider for medical advice and treatment.